Hello, welcome everyone to this presentation, What Works is What Matters. And this report's on a study that explored the question, how do care workers in care homes learn to care for people living with dementia? And this was my PhD study. So I suppose the first issue to address is actually, don't we know the answer to that question already? And I think particular in relation to training, a lot of people would say we do know the answer to that. We know that training is important. However, when you dig into the research around this area and the evidence that exists, what actually emerges is a far more complicated picture. And it shows that training has a very complex relationship with care quality. It's important, but it's not straightforward. But what does exist is a very strong rhetoric that training is key. You look at workplace learning research, which tends to take place across a range of different professions and not necessarily in health and care work. What you see is that learning occurs in a number of different ways. And most often it occurs in quite complex, informal ways based in interactions during the day-to-day events of doing the work, that it depends on the work type and it depends on the relationships that occur within a workplace. And equally, when you look at what person-centred care is as the gold standard that we're aiming for in dementia care, we know that it's social by nature. It's about relationships and communication between the caregiver and the care receiver, and that's affected by the context within which that interaction takes place. And so when you put those two factors together, actually it points us towards needing to question that strong rhetoric that training is the only thing we need to consider when we think about learning, or how learning and supporting workers may well actually help us to improve quality of care. And so that's what I actually set out to explore, is to say, I think there might be a piece of this jigsaw that's missing. And so I want to explore learning within that workplace of a care home. And so I explored two care homes that were quite different to one another. And I explored it using ethnography. I spent 6 months, about 2 to 3 days a week during that time in each of those care homes, undertaking observations, interviews, doing documentary analysis, covering in total about 20 residents and 33 staff. And what emerged from that really was a tale of two very different care homes, but two very different care homes that had very similar learning processes going on within them. They just resulted in different outcomes. So that tells us something important. That tells us that there's a process that's going on within care homes, but that it's something within the care home itself that affects the outcome of that process. And that's what I'm going to go on to talk about. So this is the learning to care process as it emerged from my study. And you can see in the middle of the slide there that you have the care worker in the middle. And that care worker every day is engaged in situations where they're having to learn new things or apply previous learning to different situations. And so there's a day-to-day learning mechanism that they're engaged in. And that's what's shown in blue there. And within my study, that was referred to as what works is what matters. So every action, every situation they encounter, they have to decide what to do. They have to decide what action to take. And they decide what to do based on what works. And if it works, then they will do that same thing again. They will learn that. They will pass it on to other people. They will share that with other people in the service. So it's about what works being what matters in terms of what they learn. And actually, when you delve down into that what works process, there's actually kind of 3 different themes that are within that, which I'll unpick in the next slide. But you'll also see on the other side of the screen there in green, that there are also skills and knowledge that the staff draw on within that day-to-day learning process. So these could be personal resources, these could be because of influences from residents directly, or they could actually be care home cultural knowledge. And care home cultural knowledge is made up of training, and most significantly, it's made up of their interactions with their colleagues. And you'll see that care home cultural knowledge there is much bigger than the other 2 factors. And that's actually because it's the most influential in terms of what staff draw on and what's available to them in terms of that what works is what matters process. So here's a little bit more about what works is what matters and that learning process. You can see that there are those three different ways that this plays out. It plays out through seeing results, it plays out through negotiating conflicting pressures, and it plays out through getting thrown into the deep end. So in terms of seeing results, staff can learn by seeing results for residents. They can learn by seeing results through fulfilling expectations of their role. And they can see results by trial and error as well. And all three of these occurred in both of the care homes. However, there was a different emphasis in each of the care homes. And you can actually see that if you look at the two quotes that are shared here, that you can see one of the homes, Strauss Hill Court, this was the home that was far more person-centred in the care that it provided. And they tended to learn most by seeing the results for residents. Whereas in the other home, Sunshine Lodge, it was seeing results that fulfilled expectations that influenced their learning the most. And that was something that led to a far less person-centred outcome in terms of the care they provided. For negotiating conflicting pressures, this was something that workers highlighted was just simply a part of their everyday job, that it was just accepted. There were always going to be conflicts about what they could do and what they could achieve, and that therefore part of their job and part of their learning was simply about learning how to deal with that and how to get to the right solution in those conflicts. Whether that conflict was about resources versus needs, or whether that was actually about interpreting the different expectations that were on them. Another part of their role that was just inevitable was this idea that they're often thrown in at the deep end, and that getting stuck in, the ability to get stuck in, was actually a key part of being able to do this work. Because so many situations, particularly when caring for people living with dementia, could be really unpredictable and that you couldn't plan in advance. And there was also a sense that this was especially the case at the beginning of the role, and that new workers experienced this one in particular. So these are all the things that are going on every day for workers as they go about their job. And that means that gives us some things to think about if we are concerned with the practice that staff are learning and how we influence it, and things to think about that are not simply about the training that we provide. So we might want to think about how we address the definitions of success that occur in a care home. What's actually seen as a good result here? Does it relate to resident well-being, or is it more about achieving certain expectations? Equally, are we actually explicitly identifying the conflicting pressures that care workers feel that they have to negotiate? And when they have to do that, are they able to choose a person-centred option? And if not, how can we put something in place to help them do that? How much do we every day encourage and facilitate staff to engage in reflection and discussion about what they're doing? Because every one of the processes on that previous slide is a reflective process, but none of the staff recognised it explicitly as that. And actually it's going on in a very unconscious way, whereas we could make it a far more conscious way and therefore influence it more. Is experimentation in terms of trial and error encouraged? And how do we share the results of that with others? And how do we sort of value the negative knowledge about what not to do as well as about what's right to do? And what do we do to try and make that deep end shallower, particularly for those new staff? How do we make some of that problem solving and the difficulties that staff face much more explicit so that we can talk about the problem solving that's required? And just a reminder here of that diagram from the beginning, that while we've seen that blue process in action, and I've explained a little bit more about it, staff are drawing on their skills and knowledge as they're going through that process. And that the most influential of these is cultural knowledge, and the biggest contributor of that is actually interactions with colleagues. And whilst there's a lot more depth I could go into about those different factors in green, there are also some additional things to think about that might help us if we're wanting to influence those factors as people who are concerned with staff development. So, for example, how does the organisation of work tasks and work teams impact what can be learned in a setting? Are we making sure, for example, that staff get to have contact with a wide range of people, work types, and get to experience lots of different types of person-centred experiences? Or actually, is that very narrow? Because when it's very narrow, we are limiting their learning experience. Are we addressing the interpersonal skills of staff, their ability to build teams, to communicate with each other, to give feedback? Are we considering how we skill certain individuals in terms of reflective and facilitation skills and critical thinking? Do we make sure to actually activate the training we have, the more formalised training, within those informal processes of what works is what matters? So, for example, through reflective activities. And are we considering the gatekeeper tasks? So these are the training that staff go through that determines whether or not they can be a care worker. Are those dementia-specific skills? So are they about communication and interpreting behaviour? Are they interpersonal skills? Or actually, are they more about things like manual handling? And if it's the latter, what message is that sending about what's important in this workplace? So, short presentation about quite a complex topic, but I hope that's helped to give you a little bit of food for thought. In terms of what next, I would be saying, I think as trainers and developers, we need to think more critically about that difference between training and learning. There are opportunities every day to influence staff learning, but we don't make good use of them. Relationships and communication matter to learning. They're not just the outcomes of learning. And we need to consider the influence of those structural factors in terms of how we shape the opportunities for learning. I'm in the middle of developing some plans to create resources for care home staff and educators and families. And one of those is shown on the slide there, a poster that summarises some of these findings. So if you want to know more, please feel free to get in touch or ask in the question panel now that it's time for questions.
Hello, welcome to Developing Person-Centered Care Around the World with the Best Practice in Dementia Care Learning Program. My name is Wendy Perry, and I lead the Learning and Development team at the Dementia Services Development Centre, which is located on the beautiful campus of the University of Stirling in the Scottish Highlands. When the Dementia Services Development Centre was created in 1989, the focus was specific to the impact of the environmental design on the health and well-being of people living with dementia in residential care and in acute care settings. The multidisciplinary team of researchers, designers, and construction specialists primarily engaged with the care homes and hospitals to identify good practice in the design of the lived environment and translated that into design guidelines to create more specific dementia-friendly services and spaces. However, as dementia became a more prominent issue, especially in the aging culture, such as the UK, the center began addressing the need for well-trained staff in the environments that they were consulting on. Staff in these services needed a deeper understanding of how they could support people living with dementia, as well as how to utilize the elements of a dementia-friendly environment. It was vital to bring together the design element and staff development, of the design element and staff development in order to strengthen service provision and to create more person-centered care. Over the ensuing 30-plus years since the center was founded, we've seen a dementia-friendly design move from a concern for the care sector into the public domain in the quest for dementia-friendly public spaces and communities. Likewise, the understanding of dementia has now been prioritized more often in public settings and community-based services. Today, we're going to look at the evolution of our workforce-based education program that followed alongside our dementia design guidelines, and which has now rippled out from Scotland to be adopted in new places and in new ways. In 2007, the center worked with Shirley Law, a mental health nurse who was running a dementia center assessment ward in a hospital setting, in order to identify the learning needs of staff who were working in that setting with people who had dementia. From these learning needs, the first draft for the best practice learning materials were developed. It's notable that this was prior to dementia becoming a national priority, and prior to the UK dementia strategies being released. In 2008, DSDC ran pilots of the healthcare version and the care home version of the course. In 2011, the materials were adapted for use in the domiciliary care. And in 2016, we saw the development of versions for accident and emergency staff and first responders, as well as a version for staff who worked in the senior housing sector. Each edition covered the same topics, but the learning activities and reflective discussions were tailored to situations which might be encountered by staff working in that specific area. All editions were developed in consultation with the workforce, professionals in the field, and adjusted as required following the pilots of each new version. In 2017, the DSDC signed a license agreement with the Jockey Club Center for Positive Aging to deliver best practice facilitator training in Cantonese. While the initial training provided by the DSDC was done in English, the program materials were translated into Cantonese for ease of use in the local workforce. In 2018-2019, the DSDC entered into another license partnership with HR Care SRL in Italy, and materials have since been translated into Italian. The program is designed as a train-the-trainer model, and over the past 12 years, the DSDC have trained over 2,000 best practice facilitators or trainers who then go on to provide best practice and dementia care training in their workplaces. They in turn have trained 11,500 registered and non-registered staff within health, social care, and the voluntary sector using the best practice and dementia care program. This workplace-based training happens in small groups and takes 4 to 6 months depending on the version being used and the time constraints of the organization. Each facilitator receives all of the materials for 8 learners and a detailed guide with lesson plans for leading the small groups. Each of the learners within the organization are required to do some independent study of the materials and participate in scheduled group discussions. Upon completion, each learner writes a reflective essay, which is marked by the learning and development tutors at the DSDC before receiving a certificate of completion. Not only has this program been successfully implemented all across the UK, we've also trained best practice facilitators across the globe and have 2 licensed partners in Hong Kong and in Italy. The course materials have been translated into Cantonese and into Italian, and there are best practice in dementia care facilitators operating in Germany, Singapore, Gibraltar, Australia, New Zealand, Malta, and Ireland. In 2014, an evaluation of the best practice in dementia care program was carried out by researcher Carrie Vizelke, in which 100 program participants were surveyed. There was a review of 60 reflective essays from the course and 89 online surveys of the managers who had staff participating in the program. Participants rated the changes in their knowledge and attitudes toward clients with dementia quite positively, and they indicated that the group discussions and exchanges of thoughts and ideas between colleagues to be the most impactful element of the program, followed by the opportunity to develop a more confident approach to caring for people with dementia and to supporting behavior changes that can happen when the individual with dementia becomes distressed or has unmet needs. Of the 87 service managers who had staff participating in the best practice in dementia care learning program, who reported back on their experience, 92% said that the program had positive impacts on the well-being of their service users with dementia. 86% said that the program had positively impacted on staff morale, and 77% said that the learning in the program had benefited the approach that they used when they managed adverse events with people living with dementia. In 2016, the Jockey Club Center for Positive Aging in Hong Kong began discussing the potential for licensing the best practice materials. And in 2017, JCCPA and the DSDC at the University of Stirling signed a partnership licensing agreement whereby DSDC provided initial training and the materials to JCCPA on the best practice program, and they began the translation process with the materials. Following the translation, the newly trained staff at JCCPA began to train facilitators in Cantonese, who were then able to return to their workplace and implement the best practice in dementia care learning program with translated and adapted materials. The goal for the JCCPA was first to train JCCPA staff and then offered to train facilitators for other organizations in Hong Kong. JCCPA conducted a large-scale evaluation of the best practice program as a study of increasing workforce capacity. In this study, 1,069 learners were surveyed prior to training and then followed up again at 12 months post-training. The study found significant improvements in knowledge, attitudes, a sense of competence in staff, and in job satisfaction levels. This is particularly notable, as most dementia training research has failed to find an impact on job satisfaction. These significant results were attributed to the crucial design elements of the training program, such as the cost effectiveness of the train-the-trainer model, which allowed for training both of care and non-care staff. This in turn supported sustainability of practices and organizational culture changes. The researchers also remarked on the importance of using reflective learning, saying, the reflective learning approach enabled learners to actively develop practical knowledge in bridging the gap between theoretical knowledge and reality in care settings. Instead of teaching one-size-fits-all management strategies, the learners had to exercise their own judgment in deciding which strategies would well address individual concerns on the basis of the principles of person-centered care. I'd like to share with you now a video from the JCCPA project lead, Dr. Kenny CHUI, who's been responsible for material translation and project implementation.
Good afternoon, honorable guests. My name is Kenny CHUI from the Jockey Club Center for the Positive Aging, and I'm very delighted to have a sharing in these sections. So thank you very much for Wendy's introductions, and I would like to share the screen first. First of all, you can see our Hong Kong version's best practice program. So we have tried to done a different kind of booklets into the Chinese version. And then the second one, actually we do the regular meeting and get the support from the DSDC. We have the regular learning from the Ms. Perry. Also, every 2 months, we are trying to discuss about the knowledge. We also receive some administrative guidance from the DSDC. And also we would like to discuss on how to support the participants and facilitators during the learning of the best practice program. And what is the challenge in Hong Kong? First of all, is the translations of the booklet and the teaching materials. We need to make some adaptations on the legal perspective and the case study. And then the second challenge is talking about different cultures and structure of NGOs. So we would like to make some flexibility to match with the needs of the NGOs. And the third one, we would like to do and solve the challenge is talking about the different levels of dementia care knowledge. So we would like to make one more day training to equip the participants the fundamental concept about dementia study. There's a little bit differences with the UK one. And what is the benefits of adapting the best practice program? We have done the social impact analysis in Hong Kong. We are talking about the individual level, the community level, and also the project and organizational level. I just have a quick highlight. The individual levels, actually, they have more confidence to apply the PCC program in their service setting, and also their job satisfactions has been enhanced. For the community level, actually, majority of the facilitators can play a very key role in their own organizations, and they have done some learning cycles within the agency. And the last one is talking about creation of a localized PCC language in changing the care culture and have the mutual health professional support groups. It's very important to have the mutual learning and enhance the dementia care services. And we are delighted to have the award from the 7th Elderly Care Innovation Award. So this is one of our awards. And also, we have the graduation ceremony. We have over 200 professionals join the best practice program in Hong Kong. The last but not the least, we have different classes. And so we would like to thank you for DSDC support. And also, we would like to have a blessing. We stay strong and positive in our COVID-19. Thank you very much.
Thank you, Dr. CHUI. You'll hear more about some of the excellent work that he's doing during this session. Though cultures may vary, knowledge and the impact of dementia and their practices involved in upholding personhood and identity are translatable, and they greatly benefit care staff, service providers, as well as people living with dementia and their families all over the world. If you have any further questions about this project or would like to inquire about our work in dementia education or dementia-friendly environmental design, please feel free.
Good afternoon, everybody. My name is CHUI from the Jockey Club Center for the Positive Aging in Hong Kong. So today I'm very delighted to share my findings about dementia care in Hong Kong. First of all, I would like to share my screen first. And my topic is talking about the listen to our voice too, the training needs of care providers in the residential care home. What happens in Hong Kong, actually, we face quite a serious aging population in Hong Kong. It takes 18.3% of total populations for those who are 65 years old or above. And why it is important? Because dementia is strongly related to the increasing of age. And if we count those 60 to 64, actually, we have around 26.2% of the aging populations. It's a very serious number in Hong Kong now. So we have some previous study in Hong Kong talking about around 10% of the total population in the aging have the dementia or cognitive decline. But most of them actually is in the mild grade. Unfortunately, in Hong Kong, we just only have 11% of them getting the formal medical diagnosis. It's a quite low diagnostic rate. Therefore, most of the elders and the caregivers, actually, they did not know about their diagnosis of dementia, and maybe they have just got very limited understanding on dementia care. And in Hong Kong, actually, we have the high institutional rate, and compared with the other countries, we have the 6.8%. And dementia is one of the most common reasons for applying the residential care homes. So we would like to focus what happened in the residential care homes about the dementia care. And some of the literature reviews talking about the predicament of caring people with dementia is not easy. They have different kinds of emotion or physical drawing, and the caring staff face quite a lot of stress. And also they need to face some of the behavior. Some of the term called BPSD, or maybe we're now talking about this distracted behavior, right? So we need to think over how to support the care staff to take care of people with dementia in the residential care home. In Hong Kong, we have a very negative stereotyping, and we have a very negative connotations. We have the Chinese translation talking about 痴呆症. Something like you have the psychiatric symptoms and you are idiot, and something like total loss of self. And even though some of the terms cause social death, it's a very negative stereotyping to the people with dementia. And in Hong Kong, there are quite strong medical dominances talking about they have the silent symptoms, and also we focus on their illnesses and the prognosis. Some of the terms, just such as the confused and the dementia sufferers, happen in Hong Kong. So it's important for us to understand more about how we can understand the self-perception of people with dementia and how this affect the caring staff to take care of the people with dementia. We have some literature review about the institutional setting. We found out that there are lots of misunderstanding and unnecessary burden throughout their caring duties for the caring staff. And in Hong Kong or in some different kinds of countries, there are no ideal form of care methods. And actually, what kind of training or information that we can provide for the caring staff. And current training are mostly based on the medical knowledge and therapeutic interventions. It may not be enough for them to take care of people with dementia regarding the person-centered care approach. So we would like to focus more on the attitude. My study is a qualitative research. Actually, I have tried to make the in-depth interview for the people with dementia and also the caring staff, getting their understanding and perception. And second part, I try to design one sharing sections to the caring home for among their staff, so that they will know more about what is the dementia, what's the person with dementia think, and how they perceive the surroundings. And the last one, I will try to have a focus group to understand more about after the training, will they have any changes and any different kinds of changes within their learning. Here are some of the themes from the caring staff. Actually, before the training, they think that they are taking care of a naughty children, they are the psychiatric patient, and also some of the care staff will feel that their job is very harsh, exhausting, and their work is not being recognized by the others and not being understood by the others. The last one about the care staff, how they perceive the people with dementia. They use the term the troublemakers without clear minds, the desolated person without meaningful life, or even though a sufferer without the personal memory. Under this context or this perception, maybe the caring staff didn't know how to communicate with the people with dementia. So what happens when they are working in the residential care home, the context and the institutional setting make it serious. Just like living in the residential care home are doubly stereotyping as being old and sick, and they just would like to take care of the family caregivers, listen the views of the caregivers mainly. But for the residents with dementia, actually they have somehow maybe have some ignorance and maybe haven't have a good response to their requests. So they also need to follow the rules and regulations of the organizations. So the caring staff actually will follow the guidelines, right? The caring staff also are responsible and legitimate to regulating the caring environment, make it safe. They have determined the right or wrong, choose to follow up or ignore the requests of people with dementia, and also use their power to regulate the disturbance of the people with dementia. So this is before what we are doing, the house the Hong Kong's caring staff have. And after that, we have trying to go through some what we talk about the psychosocial restraint. Due to the perception is a little bit negative, and also they didn't understand much about people with dementia. So they will try to stop their behavior. Maybe some of them will try rather not to talk to the resident with dementia, or even though limited their participations of activities because they would like to keep safe, to keep calm. The resident with the dementia also scapegoated those people with dementia and avoid chatting with them. So in the care home setting, actually, those working with them, the care staff, or also the other residents, actually, they didn't have quite a lot of communications or work still. Some of the people with dementia will being restrained, the physical restraint in the residential care homes. So I term it as a psychosocial restraint when they don't understand people with dementia and don't understand much about the person-centered care. So they don't want to have the disturbance or chaos in the residential care homes. So after my interviews and some findings, I try to design the training content. I share with them about the dementia experience to let them feel and let them know what's the feelings, thinking of people with dementia. I share with them some audio records directly from the people with dementia, how they understand the surroundings. I try to introduce some key concepts about person-centered cares. And the third part, I try to share with them my findings about the perception of people with dementia to let them know, actually, people with dementia have some experience with confusion, have some experience with mood fluctuations, and also what is the perception of the living with dementia. The main idea is let them understand more about the feelings and how they perceive the surroundings from the people with dementia. The last one and the last part, I try to make some reflective exercise to let them think over and also try to facilitate them to synchronize the situations of people with dementia to understand more about empathy. And we try to ask them to think more about what they can rather than what they can't. I term it as a proper caring attitude called the Dementitude. I have do some data collections and try to do in different 2 residential care homes, and I recruit 46 participants, and quite a lot of them is the non-professional staff. And I try to do the 3 months follow-up questionnaire to see whether what is the change or perceive the change after the training. So this is the main finding talking about after the reflective training, they have 3 areas to change, talking about the attitude change, the skill changes, and also the knowledge change. The details you can see this PowerPoint slide, and later on I will try to share a little bit more. But it's very important to understand the model about the ASK model, how we can change the attitude, the skills, and the knowledge from understand more about people with dementia from their perception. This is the questionnaires. The 3 months later, I try to share with them, and their answers, actually, the response rate is quite good. It's 93.5%. And the highest mark have the changes talking about they make a positive change of caring attitude after they knowing the self-perception of people with dementia. So the point is quite high, but the lowest one is talking about they agree that people with dementia are able to express their needs. So what happened and why we have that findings? First of all, maybe the knowledge and skill took time to learn and make changes. But the attitude, actually, when you understand more about how the perception of people with dementia, and then they will have an immediate change. So I would like to focus more about how to provide the training, focus on the attitude, and how to make the proper caring attitude among the caring staff. And points to highlight is talking about the lack of support and recognition over the caring staff. During the understanding of the needs of the caring staff, actually they want to have more support and recognition about their works. And also they share with that there are insufficient training on the development on caring attitude. So how they use their language, how they take good care of them, and also how what happens and what kind of thinking from the people with dementia. Actually, they don't have that kind of training. Their training focus much on the medical understanding, the pharmacological understanding, and how to keep them safe and keep them calm. But actually, how to be a person-centered care model is very important in the training sections. And the other points to highlight is talking about the limitations and norms of care in the institutional care. How we can change the settings and the caring culture is very important. We don't want to have the troublemaker that terms, and those people with dementia actually receive quite a lot of punishment in the residential care home. How to make change of that. And also we need to address and remove the negative stereotyping of the demented concept. So the details, you can go through the PowerPoint. The last, talking about we have some limitations of this study and some bias to select the focus of data and some limitations for the sampling bias. And also maybe the researchers have some prone to the finding bias. So I would like to attach the limitation of this study. Please go through it and have a look later on. So in the future time, I will try to develop more about the ASK model, talking about the attitude, the skills, and the knowledge, and also how to develop the Dementia principle. What is Dementia? Is a proper caring attitude, how to make it better, or how to understand more about people with dementia from their perspective. So I always share that we say, I can't, we can't. And the caring staff say that I can't do that, I can't do so. But if we can try to shift and make a paradigm shift to I can, what I can do, what they can do will be better. So the Dementia is talking about think more about what we can, but not what we can't. So thank you very much for your listening, and it's my honor to be here for this sharing. Thank you very much for your attendance. And later on, we will have the discussion sections. And hopefully I can share a little bit about my findings and some of the works in Hong Kong about dementia care for the caring staff. Thank you very much.